talk and then probably discuss both the talks together. So I welcome Dr. Gaurav for his talk on combination therapy for ROP.
Is the presentation visible?
Yes, Dr. Gaurav.
Okay.
You can go on slideshow.
Good evening, everyone. At the outset, I would like to thank Dr. Diksha and the Chandigarh Ophthalmic Society for giving me an opportunity to talk on a very interesting topic of combination therapy for ROP. So when I was given this topic of combination therapy for ROP, so three things come to my mind. So when do think of combination therapy? So why not anti VEGF monotherapy? And which injection to give? And what is the timing of laser treatment? So in most cases with treatable zone 2 ROP, laser should suffice. As Dr. Dogra was talking, this is a baby of an ophthalmologist who presented to us at 38 weeks and 4 days of post-gestational age, and this has severe threshold ROP. And I have done laser anterior to the ridge as well as 3 to 4 rows of posterior laser, and 6 weeks we have a beautiful regression of all the ROP. So in a lot of these bad cases, laser will work if you have done a good laser. Also, in cases with APROP zone 2, there will be a good regression because you have done a good laser, as we have done here, laser inside the vascular loops. So where is the real issue? So the real bad cases are the APROP zone 1 cases and the posterior zone 1 cases. So this is a sub-analysis from our paper published in AGO 2013, where we analyzed the risk factors for APROP despite laser. If APROP is in posterior zone 1, or what we call as zone half disease, 0% had favorable outcome with laser alone. If APROP was there in anterior zone 1, 68% had a favorable outcome with laser. And if APROP was there in posterior zone 2, virtually 98% of the babies had a favorable outcome. So what is posterior zone 1 ROP? So this is a ROP where we can see that here only few rudimentary vessels are found. There is not even plasticines, and vascularization has not even reached the fovea. So this is a disease which is very poorly responsive to laser treatment. So in a recent series which we published, only about 20% of these eyes survived with laser treatment alone. So this was baby I treated a decade back, and this has had a very bad outcome after laser treatment. So coming on to zone 1 APROP, sometimes we have cases. So this is a classical case of zone 1 APROP with flat neovascularization, closed vascular loops. And I thought, what could possibly go wrong in this case? So I did laser, I have left out some temporal area, and we did again re-laser. But this baby had a very bad outcome after laser treatment. So what to do? And we also saw that in these cases, they are more likely to develop retinal detachment if they have a gestational age of less than 29.5 weeks, or they have pre-retinal hemorrhages. So the way forward for these cases is anti VEGF and laser therapy. So this is a case managed by Dr. Diksha and Dr. Simar at AECPGI. So this case was born, this baby was born at 29 weeks of gestation, presented at 34 weeks of postmenstrual age, and this baby had severe tunica vasculosa lentis, and this has almost a posterior zone 1 APROP with fibrovascular proliferation on the nasal aspect of optic disc on both sides, as well as there were a lot of pre-retinal hemorrhages. So this baby was injected with intravitreal Ranibizumab, followed by early laser on day 5 and supplement on day 7. And this is a picture at 9 days after laser. We can see that the fibrovascular proliferation is beginning to regress. The hemorrhages are less. The plus disease is pretty much less. And finally, at 3 months, this baby had a very good outcome. So this is how we can have a good outcome with a combination treatment. So another case, so this is a case which was born at 26 plus 5 weeks of gestation, birth weight of 920 grams. So this is a picture from the clinical file, routine case of, typical case of zone 1 APROP with flat new vessels uh, and in this case, I chose to give intravitreal bevacizumab 0.6 to 5 milligram, and I waited, for about 4 weeks, and this was just before the lockdown. So, and we can see that the vascularization is proceeded into zone 2, and from the arrow we can see that there are sawtooth shaped vascular shunts at the junction of vascular and avascular retina. And these have been described in up to 60% of these eyes who have been treated. And so I choose to laser this peripheral avascular retina. Finally, baby had a favorable outcome after laser treatment. So the other indications for combination treatment will be increased vascular activity despite aggressive laser, that is salvage therapy, or if we have poor pupillary dilation due to iris rubeosis, or if there is a media haze due to vitreous hemorrhage. So like in this case, this is a report from RP Center, and they have treated this baby for aggressive posterior ROP. They have done laser, but 2 weeks down the line, they still have a lot of plastices as well as media haze. So they have injected intravitreal bevacizumab. So we can give rescue therapy in ROP cases where we think we have done a good laser and still ROP is not, the plasticity is not regressing after maybe a couple of weeks and there is media haze. So in these cases, we can give anti VEGF as a rescue therapy. The other question is, why not give anti VEGF monotherapy? Why combination therapy is better? So the point is that in a lot of these cases, 1/3 to about half of these cases, the peripheral retina never becomes vascularized. It remains avascular. So there have been reports of late disease reactivation and retinal detachment. As late as 2.5, 3 years of age, retinal detachments have been reported. Other thing is atypical neovascularization and traction bands have been reported. And even in the Rainbow trial, only about 38% of infants in the 0.2 milligram Ranibizumab group by 25 weeks had full vascularization of the retina. So just to give an example, so this is a baby, this is a child who presented to us with a total vitreous hemorrhage at 11 years of age, and this was actually a when I took the history, this was actually a premature child born at 7 months of age and with a birth weight of 1.5 grams. And these arrows show that there are peripheral NVs from which vitreous hemorrhage has occurred, and we plan to laser this peripheral avascular retina in this case. So the other thing is timing of anti-VEGF injection. So as we know that there are different phases. In the initial phase, the VEGF is underexpressed, and there is then upregulation of VEGF, and again there's a downregulation of VEGF. So earlier than 30 weeks, if we give anti-VEGF injections, so we run the risk of cessation of vascular growth. And if we give anti-VEGF once we have a lot of fibrous tissue or fibrous component of or some tractional component, we run the risk of having crunch retinal detachments. So as Dr. Simmer has very nicely shown, so any of the anti-VEGF, including bevacizumab, ranibizumab, aflibercept, they can be used. And the timing of laser after anti-VEGF, so if the neovascularization is florid, if there is pre-existing fibrovascular proliferation or hemorrhages, so we are going to add in an early laser after we have given anti-VEGF. So the other scenario is if we have a zone 1 or a posterior zone 1 disease which show limited vascular growth or limited vascularization. So we will give anti-VEGF, wait for vascularization to proceed to the periphery. So for all of us who are in private practice who do not have the facility of fluorescent angiography, usually after ranibizumab, I like to go in with laser at 4 to 5 weeks, and with bevacizumab, I tend to go with laser at 6 to 8 weeks after bevacizumab. For those in institutional practice who have the privilege of fundus fluorescent angiography, like Dr. Simmer and Dr. Diksha do, so they wait for around 65 weeks and they do a fluorescent angiography. And if they see peripheral neovascularization or peripheral NVs, they tend to add laser. So going by my own experience, so this is the data of the last 6 years. This is just with the green laser alone for ROP, 252 eyes of 130 infants. So most of the cases will do well with laser, even zone 2 APROP, atypical zone 2 ROP, as well as most of the staged ROP will do well with laser alone. The real issue comes when you have late presentation with threshold ROP. These are the cases we have to do laser and later they will need a lens sparing vitrectomy. And definitely APROP zone 1 with laser alone has a suboptimal response. And here we do need a combination therapy in a lot of cases. So we have done combination therapy in 15 odd eyes, most of them APROP zone 1 eyes, and we have used both bevacizumab and ranibizumab followed by laser, and all these eyes had a favorable outcome. So coming just a word about the Rainbow trial. The Rainbow trial compared the efficacy of 0.2 milligram ranibizumab with 0.1 milligram ranibizumab and laser. The problem is it did not include stage 2 in zone 2 ROP with plastices, which is a substantial proportion of treatable ROP according to ETROP. Another thing is it did not differentiate the stage 3 ROP into pre-threshold and threshold stage 3 ROP. So now, as far as the treatment success was concerned, 80% of infants receiving ranibizumab had a treatment success compared to 66% infants with laser therapy. The problem is laser was not standardized because it was multicentric and it was not same across all the centers. So another thing I want to emphasize is even in this Rainbow trial, treatment switches were common, and nearly 1/6 of the infants, that is 15.71% of the 70 infants in the ranibizumab group, they needed a switch to laser treatment. And the converse was also true, that 19.11% of infants in the laser group needed a switch to ranibizumab. So the take-home message is that combination therapy for ROP is required, especially in cases with zone 1 APROP or posterior zone 1 ROP, and in eyes who have severe TVL, media haze, or in some cases as rescue therapy. So any of the agents, including bevacizumab, ranibizumab, aflibercept, can be used. And sorry. So if we have a more florid disease, so we can go with the early laser. And if we have a limited or poor vascularization of retina, we like that the vascularization should proceed to the periphery and then we do laser treatment. So this is just some lockdown art for you. And I would like to thank Professor Amar Dogra, my teacher on this Teacher's Day, for teaching us not only ROP, but being an inspiration for everything. And I would like to thank my younger colleagues, Dr. Diksha and Dr. Simar.
Thank you very much.